Thank you. You see, I've taken the liberty of slightly changing the title because when actually getting to the task of preparing this talk, so the task is even bigger than initially considered. So I don't claim I have answers, but I'll take you through the kind of thinking. Okay. I am a molecular biologist who then later turned into a vaccinologist and got a bit of experience of infectious diseases and has had a good fortune of seeing the public health benefits of a new vaccine in my own country, in many other countries, and then worked quite a bit to try to get these benefits to the developing world where they would be mostly needed. Okay, so that's the start. As a molecular biologist, one would say yes, the infectious disease is a wonderful target. We should have lots of possibilities of responding to the challenge, because we have there an infectious agent that is a defined enemy, which is separate from ourselves, different from ourselves in many ways. Even if Peter was just telling how difficult it still is to find an agent that can treat differently the microbes and man. And furthermore, we already have a choice of quite effective looking strategies in the combat. We can always have a treatment possibility. We have a prevention possibility. Okay, so then and we do have a demonstration of successful approaches, as you know. We have the dreaded diseases in the past have disappeared, at least from around this place, and the life expectancy has increased, child mortality decreased, all to a large extent thanks to reduced impact of infectious diseases. But as you know, infectious diseases are still there. They still bother us. There is an altered profile, which now means that in this part of the world, the diseases are usually mild, but they are bothering us. They cause a lot of problems to families with young children, and we have an emphasis on infections that may be underlying causes for development of chronic diseases, and not only gastric ulcer and many cancers, also cardiovascular disease may be one of those, and others. And there are new emerging diseases, as yesterday, as we talked about yesterday. But furthermore, these successes have only benefited a minority of the people, and this is then my version of the inequality equation of infectious diseases. And what I want to point out here, let's see how this works, or does it work? Okay. I want to point out, of course, is the figure here, that is the great inequality in mortality in children under 5. It's about 10 times higher in some countries than in others. And now this difference in the mortality is almost all due to infectious diseases. The difference is is here listed according to the economy, and it truly is a fact that this is not a question of tropical diseases only. This is a question of the pathology of poverty, only a small part, maybe up to 10% of this additional mortality is due to malaria, atypical tropical disease, and the rest is mainly due to diseases that are equally common with us, but not lethal. That is diarrhea and respiratory infections. And that is the additional problem. Of course, it is expanded by the fact that a much larger proportion of people live in these low-income countries than in the well-off countries. Okay, so the response of the molecular biology, of course, is research and development that is born from the research. And that is, of course, because that is our profession. That is what we can do and what we think we can do well. And at this time, it would seem that, yes, we do have wonderful possibilities. Never before had molecular biology such tools to attack the problem. And we do have all the wonderful data on the genomics of the microbes and of the host, and even the vector in between. And we have all the possibilities to learn and understand better what happens in the interactions between the microbe and the host during the infection. We have a list of various tools that could be made, and one can just use doesn't need much imagination from the molecular biology standpoint on seeing what wonderful new developments in antimicrobials, vaccines, etc. one could make. However, there are difficulties here. Firstly, there are biological challenges towards making, for example, antimicrobials, and I don't need to go into them. That was just discussed in Peter's talk half an hour ago. With vaccines, there also are biological challenges that actually might mean that it will not be possible to have a vaccine for every infection, and HIV might be one of those. I hope it is not, but okay. So but there are other problems than these biological challenges. Those we can sort of take and handle. We think that that makes the work more exciting, and might be able to find even greater discoveries. But there are other questions, and these are the three main questions that I've listed here, which I think are of important concern. First one is that is our research agenda, does it have a right focus? Secondly, we have the cost issue. We have an implementation issue. I'll be talking in detail about this. So first about do we have a right focus? Yesterday's showed that we do not have a right focus. There are a number of neglected diseases which are getting a much smaller share of the research investment that we have. And the reasons for them being neglected, or actually the mediators of them being neglected, are the financial questions. Industry is not interested. That is what we discussed yesterday. There is problems of public funding. I have put here a question mark because this was very much my experience in the small country of Finland. We yesterday heard that it was a big problem. A similar problem came up in Germany, that the public funding is not seeing these neglected diseases as of importance. And finally, the public funding might not be sufficient as as new development of new drugs, new vaccines is a more expensive procedure than public funding is used to handle. Okay, so we say no, there is not the right focus. We have many important diseases that are neglected. But it goes further on. I can say that infectious diseases are neglected diseases. There is much too little funding for infectious disease, for research for improving our answer to infectious diseases. Just in addition to what has been discussed already, I'll just point out that the European Community's big research program that they are now planning, the 6th framework for the following years, has extremely little input for infectious diseases. It has raised malaria as one of the focal points. Malaria, HIV, tuberculosis, but all other infectious diseases get almost no support at all, which will certainly mean decrease or disappearance of research groups or moving to other fields. Okay, so then furthermore, is there focus right in terms for treatment and for prevention? And this slide borrowed from UNICEF is just telling that the market share of vaccines, that is prevention, is extremely small. Okay, then we come to the cost issue. We just said that, and it basically says that the new products that are now developed are more expensive than old ones as a rule. And the reasons for that are varied. The new technologies may be more expensive, but the research and development costs are getting more and more expensive. And I think this is, there are several aspects to this, and one of those is one very important part of those is the increasing demands on proof of safety, which was just discussed with some antibiotics. It's a very same with vaccines. Yes, safety is nice, but it means very large studies, and very large studies mean with very important precautions mean increasing costs. And so the costs of clinical trials are really getting to be so high as to be prohibitive for progress, for development. There's fear of litigation. There is lack of competition because of intellectual property rights, etc. So finally, the cost of new drugs is more expensive, and if that means that the predictions of recovery of the costs are poor, then maybe many products are not developed. The development is stopped at an early stage, and the result is that we do not get the new product. Furthermore, I'd say that there is this problem that many of the new products that we make are not sort of entirely new drugs for a disease for which there was not a drug. They are additional drugs, a little bit better than previously. And then we have an increasing cost for a little bit of benefit, and as a direct cost, as a little bit of benefit when looking at the direct cost-benefit relations, but then with a lot of indirect disbenefits of increasing the total cost of medicine, of tools available. Okay, so the consequences of the higher cost of drugs means that it does increase the economic burden of health services. In some areas, it may mean that just we have to find different ways of financing the health services. Either there is higher costs to individual patients, or the society decides to put a larger amount in the healthcare. But in many countries, this means that there is no possibility of absorbing the increasing costs, and this is creating inequality between countries. It's creating inequality between people within well-off countries as far as individual based costing is applied. And further on, it has further repercussions, and I'm taking here as an example from the vaccine field that I know of, a seemingly very innocuous new development. This is based on the fact that we had a pertussis vaccine, which is used as a combination diphtheria, tetanus, pertussis vaccine in worldwide since 1948, and WHO has made very great efforts with very great success in spreading this good vaccine, use of this good vaccine all over the world, so that the global coverage is about 80%. And large part of this DTP is produced nationally. It is produced at very low prices, which has actually made the high coverage possible. Okay, but then arose worries about adverse events with this vaccine, and its use decreased in some countries, and this resulted in the development of new vaccines that would have less adverse events. A new acellular vaccine, or a few of those were licensed in the United States quite recently, about 5 years ago. They do have fewer adverse events, so what then? Isn't everybody happy? Now, these are produced by multinational companies. The price is high. As you see, the difference to the low price of the early vaccines is huge. It didn't really matter very much in well-off countries, which decided to adopt this new vaccine that would be better accepted to the people anyway. I mean, it did mean a dent in the health budgets of these countries. Even in my northern country, this was heavily discussed, and finally we decided, yes, we have to. There is so much public pressure, we have to go to the acellular vaccine. But what it means that this is entirely impossible for adoption in the developing countries for the EPI program use, and it's then the unexpected result was that the national production dropped. They could not convert the production from the old wholesale vaccine to the new acellular vaccine. Therefore, they just dropped out of the market. And the report quite recent report from UNICEF told that a total of 8 of the 12 manufacturers who provided UNICEF with this DTP have dropped out of market. And this they have pulled out totally, so that also production of some other vaccines has decreased. So what does this? How will this story end up? I do not know. It doesn't look too promising. Okay, so that about the cost problem. The implementation issue is however the one that seems to be me greatest problem. Again, it's not a huge problem in the well-off countries. We do have good infrastructures that are there to assure that most of the new inventions and good tools will be implemented. It will mean, however, some problems to their health service planning, and especially with the increasing costs. They are used to the fact that the costs are increasing anyway. There will be a need of the health services to adapt to this. It will mean acceptance of prioritization principles, and we do not know how it goes, but it's not a huge problem. I think it will not destroy the benefits that we have. There will be some questions about where to invest in the treatment or prevention parts. But the problem is huge in developing countries, and it affects their all levels of the society, from the grassroots, that is the end users of the products, the patients and the children to be immunized and so on. Then it goes on to all levels of health services, up to the policy and planning and politics stages. Okay, I'll take an example from the acute respiratory infections, which I say is now the #1 killer of children in developing countries. And this means at about 2 million, an estimated 2 million deaths in children under 5. By the way, don't take these estimates, 2 million, whatever, as sort of as the absolute truth. The surveillances are not that good. The global diagnostics, you can imagine, are not that good that one could have rely on these figures, but they are indicative there. Actually, they are indicative of the magnitude of the question. There is no question about that. Okay, so because of the importance of the ARI field, WHO has made good recommendations in order that would help people to make the right diagnosis and associate the right diagnosis with the best treatment. And basically, these separations are made very easy. First question is, does the child have pneumonia or not? If it is not pneumonia, antibiotics are not recommended. If it's pneumonia, give oral antibiotics unless the pneumonia is severe and requires treatment in hospital. And the observation of these recommendations has actually been shown to to lead in the right direction, so that in some large hospitals, for example in Pakistan, it has been shown that the mortality in pneumonia in the hospital has decreased by 50%. But this is mortality of children in the hospital, and most of the problem is outside hospital. And that is what we have to look at in the real life. And it's here we have the actors. We do have the mother, which just this part. Thanks. Yeah, we do have the mother with a sick child. We have and the mother is actually the starting point here. She will have to evaluate how sick the child is. Does she need to go to seek care, and does she need to take the trouble and the expense of spending a day in walking to the nearest healthcare station, and maybe the money to pay for the drugs afterwards. She's being advised by her husband, by the grandparents, by in-laws, by a variety of people. But but the question is about the knowledge of knowing whether one needs to go to healthcare to seek care or not. And then if she makes the right decision here, then the next stage here is she gets to the primary healthcare station. And now the question again is there the right knowledge there? Does the nurse or the midwife or whoever is there, does he or she know know the algorithms of the recommendations, then she apply them correctly, then she end up from the right diagnosis to the right prescription. And I must say it is easy to err if one does not have very good confidence in oneself, very good training. That, for example, there is a pressure of giving antibiotics. So to decide that the child does not have pneumonia, does not need antibiotics, is not an easy decision. But and it results, in fact, and that is demonstrated in many studies, in more prescriptions than would be needed, and an overuse of antibiotics, which we know and which has been demonstrated many times, results in increasing antibiotic resistance and later on with consequent less usefulness of the antibiotics. Or even the decision to send the child to hospital is a severe one because it means additional costs and difficulties for the mother who will have to accompany the child to the hospital, then who will take care of the other children at home, who will cook for the husband, etc., etc. Then in the child is in the hospital is a question, are there the right drugs there? Are there antibiotics? Is there oxygen available? Are there other drugs available? It's actually quite a chance that that one gets all these points right, that the mother knows the right thing, that the primary health station then knows to do the right thing, that the hospital system is working, that the infrastructure has provided with the needed drugs. And finally, that means that the likelihood of all this succeeding at the same time is rather small, and that means that the chances of treatment are succeeding are quite small, and that is the problem all due to the implementation. It's not due to a lack of tools, a lack of antibiotics, a lack of diagnostics. It's due to their implementation, but it is an inherent problem in the situations with treatment of infectious disease. So, okay, we say prevention. Isn't that better? It doesn't depend on the care seeking of the patients or the families. And then we know that there is a lot of possibilities for prevention. All of these are sort of the old bag of tricks, but they are working. And in our part of the world, the result has been rather good. But again, there is the same problem of implementation. They are all dependent on a chain of events, of many different things happening, succeeding at the same time. For the individuals to know to apply the methods, or even to know and accept to change their behavior, which would be needed for many of these preventive measures. One needs the infrastructure to provide the materials and the information. One needs management training, supervision, follow-up funding, a lot of things. Very small chances that all of these succeed, that the prevention will work. Okay, let's look at this question of the immunization, which is one of the best working principles of prevention. And we do have the EPI program, which was created in '74 by WHO. It provides the 6 vaccines at low cost. It has established the national programs, etc. But there are problems with this. It's been difficult to increase the coverage from above this 80%. It's been staying there since 1990. Every year, the very similar numbers. And furthermore, it has been the 6 diseases, 6 vaccines that were introduced from the beginning, and very long time before any new vaccines were introduced in the system. And this doesn't look so bad. This actually suggests that yes, hepatitis B vaccine has been introduced and its use is growing. But this is nearly 20 years, about 10 years after the vaccine became available in well-off countries. So there's been a delay of 10 years when vaccine was of no use in developing countries. And its use only increased very little, very slowly, and has needed a very definite boost from the extended activities of the Gavi process. I'll mention Gavi soon a little bit more. And now our worries are that the same thing will happen with the new vaccines. We have now Haemophilus influenzae vaccine, which has been available since 1990 in well-off countries and has been very well used and found extremely useful towards the childhood meningitis. However, you don't see Hib mentioned here yet. It's only being, with introduction, is being planned only now. And then we have a newer vaccine, a pneumococcal vaccine, which has become available in US in 2000. So how long will it take before that vaccine will be used in developing countries? And that's an important question, because that together with the Hib may be the vaccines that would have an impact on the respiratory infections, on the ARI problem. That is the main problem, reducing from the 2 million deaths to something lower, and we do not have a right. We can't give a figure to how low it would go because we do not have the data. The information is just not there. Okay, Gavi is the Global Alliance for Vaccines and Immunizations. It's an alliance from a number of organizations interested in just this question, how to improve the use of immunizations in developing countries, including WHO, UNICEF, World Bank, the Bill and Melinda Gates Foundation, etc. And it has now a specific program of finding out how to accelerate the introduction of the new vaccines, that is hepatitis Hib B and Hib and pneumococcal vaccine, also rotavirus vaccine for diarrhea into developing countries. And it has its analysis tells that one needs to have more knowledge of the burden of disease in order to convince people about the necessity of this vaccine. One needs to have good knowledge of the vaccine, its safety and its effectiveness, in order to tell how much benefit it would accrue from its use. We needs advocacy to transfer this information to the people who are making the decisions, both at the local level, in the health stations immunizing children, but also in the first place in the ministries of health making decisions about use. And one needs international recommendations that would support the decisions in the local officials. One needs good planning. So all this is an analysis of what would be needed. The special point Gavi makes is that instead of waiting until these are done sequentially, to try and get them happening simultaneously at the same time, so that one might be able to result in use of these vaccines at an earlier date, which would have a significant impact on the welfare of the children. Okay, so these were examples. We heard lots of other examples yesterday. You have your own examples, but what this demonstrates is that there are huge and varied problems. And I think when I was now asking what is the message to the molecular microbiologist, I'm especially asking that this is a special question or special issue for the young people who are here, who are just developing their careers in molecular biology, acquiring all the wonderful tools that they can use. This is asking how can they use these to the benefit of the people who need it. And I think that my main message here is that important is to be aware of the complexity of the problems. Get to know what are the questions, what are the reasons behind each decision. We learned about development of antimicrobials, why it is so difficult, what are the reasons behind the apparent reasons. You see that there is not a single answer. That answer is not primarily molecular biology, but I think it still is our responsibility of trying to do something about it. And what we can do will be varied possibilities. There is not a single answer, not a magic bullet here. You should each individually consider what is needed, what you can contribute, and then pursue that line of action. For example, for the R&D agenda, you can select your topic of research, but you can inform others in the research community. You can advise the funding bodies or lobby, whatever you call it. There is advocacy. There are good advocacy groups now. There is a DNDI, is Drugs for Neglected Diseases Initiative. TDR has presented their case well. When there are things that you can do about the cost issue, you can inform yourself and act accordingly as you find fit. You can inform, spread the information. You can add again more information, advice, lobbying. There may be practical possibilities in these public-private partnerships, etc., which we will hear more about today. For implementation, what's needed is better knowledge at all levels of actors, at the local people, the mother who needs to bring the child to be immunized, the nurses manning the health stations. There needs local capacity building for knowledge, to advise, to support the work, to support the surveillance work, all that kind of thing. There's funding needed, and there is political will needed. And again, how can we interfere there? We can facilitate the spreading of knowledge. There's been discussion of partnerships and partnerships with research institutes or with various NGO activities. There's advice and lobbying that can be done. There are several initiatives that sort of can give the framework for the work. So that's a message. Please do think of these things.
Thanks very much, Helena, for addressing this topic of this morning's discussion from a very different angle than before, and a very important angle to complement the topic today. Do we have questions for Helena Maekelae?
Hello. Hello. I'm Andres Gaitan, one PhD student here at EMBL. Excuse my ignorance, it's only that I don't know the meaning of, when you were explaining the tools that are available thanks to research and development, you have, well, there was a slide with symptomatic RX. Could you explain what does?
That means drugs that alleviate symptoms. you have a common cold. You would like to have something that prevents you from sneezing or feeling a headache and whatnot.
My name's Richard Brown. I wonder whether you know why 8 out of 12 companies dropped out of the field. This leads to a very, very small scale of production. What are the reasons behind companies getting out of this?
The reasons are that more and more countries are moving on to the acellular vaccine. So the companies who are making the old-fashioned vaccine decide that there is no future for them. Right, and it just happens that the obvious alternative would have been to upgrade their production systems so that they move to making the acellular ones. But then there are patent rights that prevent it, and the technology is much more expensive and more difficult, so it's beyond their capacities. I know this rather well because one of those national companies that dropped out of business was our public health institute in Finland.
Not being that young myself anymore, but still putting together what Peter said initially and what you said very much during your talk. Many of the problems are there for a long time. It's old problems to a large extent. And many of what you put up as what we can do is advise, politician advice, international bodies and so on, are also there for quite some time. So what's your hope how this can be improved?
Getting through the activity of the angry young people who decide that having these problems for 20 years is enough.
I guess I'm too old for this, so you should listen up there.
I'd just like to say most young people are oblivious to all these problems, so there's no hope in... I think most young people are oblivious to all these problems, so they don't even have the knowledge to be getting angry about. So chances of that happening are very small, I would think.
Right. Yeah. Yeah. So spreading the knowledge is the first recipe, I guess. That is something that I had in mind when I put knowledge in the title of my talk.
Which is what I guess this conference is trying to do. The question is only, does it address the right audience totally to achieve what it's supposed to do?
It's interesting after hearing your conversation. Up until 1990-91, the World Bank's position on public health was that public health would improve only as a corollary of overall economic development. So putting money into building airports and factories was preferable to directly funding anything related to health. In 1991, there was this market shift at the World Bank, and now the World Bank is the single biggest funder of public health in the world directly. Your whole presentation almost seems to challenge a reversal to the previous view, that in the absence of an appropriate infrastructure at the ground level in a developing country, you can't have implementation of public health.
Yeah, these tend to be sort of vicious cycles that which are difficult to change from one end to another. You do need some infrastructure to implement things. That is definite, but it's not necessarily airports. It's more like putting. I think that for World Bank it would be advice would be more in putting their money in creating the practical infrastructure from the bottom up in these countries, rather than building sort of big electricities, roadworks. Yes, one needs, but I mean, it's difficult because poverty is the common problem. Improving the finances, economies would improve things, but not without still specific effort on the health question, on the public health questions. I'm sure.
One more comment or question.
But that is actually seen also by sources from World Bank in a different angle. They calculate that investment in health brings an interest rate of about 20 to 25%, whereas in industry of 12%. So the only thing is, and that is also activities which are picked up by the European Union in this way, and not only, actually worldwide, that investment in health will be accompanied by investment also in implementation plans. This means if you invest in health and also to some extent in industry, by giving additional funds to those countries where the net product declines so much as it does in Africa, by 6% per year in some countries. This will be accompanied by obligatory investment of those countries of a certain percentage of their funds in health. And this is, I think, the message and the only way how we can really help them to help themselves on the long run.
Okay, we have no further question right now, so